Hello, my name is Brianna Kugelmeister, and this is my care plan final project. The client I decided to do my care plan on, her name is Lisa. She is a 51-year-old female. Um, she is 5 feet tall, weighing 183 pounds, and her diagnosis is metastatic colon cancer. I decided to do my presentation on her because I had taken care of her throughout her battle with cancer. From start to where she is at now, and I also am friends with her son, so I also know a little bit of background into her life. Alright, we'll start by talking about this psychological variable. This deals with the body structure and internal function. As we know, that cancer patients undergo many drastic changes as they go through their treatments, including the chemotherapy and the radiation. Both can have drastic effects on how our body functions and can disrupt many of the internal processes that normally occur in a healthy, functioning body. All right, the medications that Lisa is currently taking are Eliquis, Carvedilol. She's taking a fentanyl patch, Lasix, Aldactone, Reglan, Remeron. Daily heparin flushes to report, and she is on a dilaudid PCA. And she takes as needed Tylenol, Tums, Flonase, Zofran, Miralax, saline nasal spray, Dilaudid, clonazepam, and Ativan. Vaccination and allergies. She received her Tdap vaccination on March 8th in 2015. Because she is a cancer patient, she was unable to receive her influenza and pneumonia vaccine due to her immunocompromised state. And as far as her allergies go, she is allergic to atenolol. When she does take that medication, she does get extremely fatigued. And then with the felodipine, she gets headaches and flushing. And then sulfa antibiotics cause her to get yeast infections. Alright, and some of the psychological or physiological stressors that Lisa had undergone are her white blood cell count with the chemo. She did become very immunocompromised, and that put her at a high risk for infection to intrude into her lines of defense. Her red blood cell count was also diminished with the chemotherapy, making her very fatigued, tired, weak, and unable to do the activity that she was doing prior. Her platelet count was also compromised. She did not have any effects from this, but there were potential that she could have a serious bleed, whether it be a brain bleed or internal bleeding, because those platelets are very low. Because of the cancer spreading internally, she had a lot of pain, specifically the abdominal area where the cancer had invaded her liver and colon. And then also constipation due to the metastatic cancer in her abdomen and the primary source of it being colon cancer. She had many tumors blocking the path that stool would normally go through, and with her lack of activity also causing constipation as well as the pain medication she was on. Normal line of defense. When we look at this is the adaptational level of health developed over time and considered normal for an individual. So this is very individualized to each person. Um, and in Lisa's case, her normal line of defense sadly was diminishing from day to day. Her activity level was decreasing from being able to do everything from cooking, cleaning, doing the grocery shopping and driving, down to now bed rest with minimal assistance to get up and go to the bathroom. But other than that, basically spending her day in bed. And as far as eating, that also diminished to barely taking in a few sips a day and a few bites of food now and then. The flexible line of defense review. This is the protective accordion-like mechanism that surrounds and protects a normal line of defense from the invasion of stressors. Some things that cause the flexible line of defense in Lisa's case to get penetrated were the chemotherapy that we talked about affecting her blood counts and the metastatic cancer, which affected her bowels and pain and activity levels. All right, so now we're going to talk about environmental interactions. So we're starting with interpersonal interactions, and as we know that intrapersonal interactions are defined as forces that occur within the boundary of the client system. In Lisa's case, we saw that her blood counts declined after receiving her chemotherapy, and a lot of times they did recover on their own, but her body was susceptible to succumb to some bad infections because of that low white count that she had, as well as the anemia causing her to be tired, and the platelet count causing her, or didn't cause her, but put her at risk for serious bleeding complications. Interpersonal interactions, as we know, are defined as external environmental forces that occur outside the boundaries of the client's system at the proximal range. So in Lisa's case, we think of her interactions with her family. So her family role, she was a mother to her 2 children, where she would do a lot of the cooking, cleaning, and she also had a job that she would provide groceries for her family. And then her role as a wife to her husband, helping him pay some bills, and also providing meals for him. And then she was also a grandmother to her 3 grandchildren. And as her disease progressed, these roles were not being fulfilled to the way that she was used to. Extrapersonal interactions, we know that is defined as forces that occur outside the boundaries of the client system at the distal range. And then in Lisa's case, we see these interactions with financial issues. So Lisa, being a cancer patient, accrued thousands of dollars of medical bills with her family, that her family is now trying to scrounge up that money to make those payments. And now that she is not able to work, she is unable to supply any money towards any of the bills, leaving that burden on her husband. And also the burden of trying to figure out the insurance company and what is covered versus what isn't covered. So with Lisa's assessment, she was alert and oriented to person, place, and time. Starting at her head, I found her mucous membranes were extremely dry due to not taking in any oral hydration. She was receiving IV hydration, however, was still very, very dry. And a lot of the fluid that was on her had third spaced. Respiratory, her lungs were clear bilaterally throughout. Her breathing was shallow, but not distressed at all. And her respiratory rate was between 12 to 14 breaths a minute. Cardiac, her heart was strong. S1, S2 sounds were heard. Her radial pulses and pedal pulses were strong, and she denied any lack of sensation or numbness or tingling to her hands or feet or any part of their extremities. As far as GI, she had a colostomy that was beefy red, and the appliance and bag were intact. It was putting out brown liquid stool. And at the time of being in the hospital, she was also putting out loose, bloody stool via her rectum. And as far as urinary, she was urinating just fine. She was receiving aldactone and Lasix after receiving her albumin. So she had a little bit of frequency as far as urinating, but it was clear yellow and an adequate amount. And as far as activity, Lisa was getting up by herself with a standby assist, not ambulating in the halls, and very weak compared to her baseline. Alright, next we're going to be looking at the psychological variable, and as we know, this refers to the mental process and interactive environmental effects, both internally and externally, of our patients. And as we look further into this, we'll be looking at the coping mechanisms that Lisa has, the stressors, and her priorities as far as treatment. Coping strategies. So when thinking of coping, I think of the stages of grief, denial, anger, bargaining, depression, and acceptance. And as taking care of Lisa, I had seen her go through many of these stages. Upon her initial diagnosis, her and her family were in slight denial of how serious the actual cancer was at that point. She stated that she felt numb at this point, and just couldn't really wrap her head around the concept of having stage 4 colon cancer. She then proceeded to be angry, wondering why this was happening to her. At the age of 51, she still had a lot of life left ahead of her and was not ready to face this battle. I did not really see bargaining as a coping strategy for Lisa. I think this might have been more an internal thing that she really didn't express. And as her disease progressed, she did have periods of depression, especially around the holidays this year, when she was at home for Thanksgiving and Christmas, not being able to partake in a lot of the activities and the food because of her nausea, vomiting. She had tried taking a few nibbles here and there of different things and would get sick. And I think seeing her family together really brought her down. But she was started on Remeron, which seemed to increase her mood. So you see the medications that were helping her. She also has clonazepam and Ativan that she was taking as well when she was having a lot of anxiety or a hard time sleeping. And then she had her family with her. She has three sisters and a brother, a son that lives at home, her husband, her daughter, um, and her three grandkids, as well as a lot of supportive neighbors and other people that were able to help her get through these hard times. And as her disease continued to progress to the point of not responding to any of the therapies, she did have acceptance in the fact that she does only have months to live from now on out. She had made statements of, planning her funeral and getting her family prepared for what was to come. Psychological stressors. So Lisa has a sister that also has terminal cancer and is on hospice as well. And this is a big stress for her, as well as her other sister, who just can't quite wrap her head around the fact that both of her sisters are terminal, and she just is not ready to lose both of them because they are both younger than her. So Lisa deals with the stress of talking with that sister as well as losing a sister as well. She's also very stressed about her husband. She feels that she is a burden on her family. Instead of being able to help pay the bills, she is now a reason for financial concern. She has the stress of her son, who doesn't communicate well how he is feeling about the situation, and also goes out to the bars frequently and drinks heavily, which concerns Lisa for his well being after she is gone. Her daughter, she's concerned about her daughter's marriage. Her daughter is not in a happy marriage and fights often with her husband and has a lot of financial concerns and puts the grandkids in a bad situation. And Lisa is extremely close with her grandkids, so she worries about their well being after she is gone. And as I had said, the burden on the family, which she feels she has become. And also the fear of only having 3 months left to live, that fear of death and not finishing everything that you wanted to here on earth in the time that you were given. All right, so her priorities as a patient. Initially, when she was diagnosed with cancer, of course, her initial priority was to receive chemo and whatever treatments that were out there to cure the cancer. However, after receiving the first chemo and coming down with pancreatitis, not able to receive that chemo anymore, they then did surgery to remove the mass in her colon. And after a long recovery, they did a scan and found that the cancer had progressed. And really, the only option from then was to do palliative chemo. So her next priority down the line was to prolong her life with the palliative chemo. So they did that for a few weeks. It seemed to be helping. However, she had come down with some excruciating pain and was found that her cancer had spread further and that the palliative chemo was not effective at all. So then her priority became to go on hospice and live her remaining time here in comfort. So she has a PCA at home where she is getting pain medication and able to keep herself comfortable. The sociocultural variable, as we know, this refers to the combined effects of social cultural conditions and influences. So we'll be looking at just some personal information about Lisa as well as her finances. So some just general information about Lisa. She was married shortly out of high school after her first child was born, Jamie. And her and her husband then had their second child, Dan. Um, and things just were not working out with their marriage, so she did get divorced. And shortly after divorce, she met her husband of 22 years now, Dave, and they have been happily married ever since. Her daughter Jamie has 3 kids, so she does have 3 grandchildren. Calissa, who is 3, Kobe, who is 11, and Keaton, who is 13. Um, Before getting diagnosed with cancer, Lisa ran an in-home daycare where she watched her grandchildren as well as other children, and she used that money to supply meals for her family as well as pay for her vehicle payments. But after getting diagnosed, she was not able to continue with her employment, and she had never had any college education. She actually dropped out of high school, but did get her GED shortly after that. So the financials, like I had said, she is unemployed currently because of being debilitated from the metastatic cancer. And her husband had to decrease his hours because he was taking care of her and spending a lot of time up at the hospital as well as at her bedside when she was home, taking care of her. And as we all know, hospital bills are not cheap, so they continue to accrue bills every day. Now being on hospice, having those nurses come in, CNAs come in, pain medications around the clock, which all add up. Next, we'll look at the developmental variables. As we know, this is referring to age-related developmental processes and activities. So we will look further into Lisa's Erikson's stages, sleeping patterns, and nutrition. Alright, looking at the Erikson stages, there are 8 stages that typically most people will go through in their lifetime. Each person's individual, so some people only get to a certain stage in life, and that's as far as they progress through the stages. And others go through all of them at different paces. So when looking at Lisa, prior to her illness, she was in the stage generativity versus stagnation. So she was happily married. She had her children. She was raising her children. She had a job that she was, helping other people. She had friends. She had hobbies that she would do. So she was doing well. After her illness, I think she fell into the stage of despair. She felt that she was a burden and that her life, she just wasn't able to accomplish everything that she had wanted to in the short 51 years that she was alive, knowing that she only has months left. Sleeping patterns. So typically, prior to being sick, she stated that she would sleep an average of 6 to 8 hours a night. As her disease progressed, those hours became longer. She spent more time in bed um, with the increased weakness due to chemotherapy. It was harder for her to get out of bed, harder for her to stay motivated. Depression played a factor in there as well. It was lack of motivation. With the chemo is also her anemia, low red blood cells. She wasn't oxygenating well, so she was spending more and more time sleeping. And today she spends most of the day sleeping. With the PCA, she is getting a lot of narcotic pain medication, which also increases her drowsiness and sleepiness. Nutrition. I think I stated before that baseline she was eating, the average 3 meals a day, um, up until she got pancreatitis. And after that, her nutrition just steadily declined until she had that colectomy surgery done. And after that surgery, she had a very decreased appetite, actually, no appetite at all. And when she would try to take even sips of drinks or food, it would cause her to get nauseous, and she would end up either dry heaving or vomiting. And with a recent surgery, that was scary for her to eat anything in fear of the pain that she would have with the nausea vomiting. So ultimately, because her nutrition was suffering, they started her on TPN, which she has been on now for almost 6 months. And that is her sole form of getting nutrition. Spiritual variables, as we know, it refers to the spiritual beliefs and influences. And as I got to know Lisa, she isn't a very religious person. She does have a religious affiliation with a non-denominational religion, and she does believe in the power of prayer, and she did spend time praying with her family a couple times that I had saw when she was up in the hospital. She had stated that after she does pass away, she would like to have a funeral at her church and have a service done by her pastor. But due to her state of health, she really has not gone to a service in a long time. But she does believe in an afterlife and believes that she will be going to heaven. So now we'll look at some nursing diagnoses for Lisa. So we have 3 wellness diagnoses. We have readiness for advanced self-care related to colostomy care as evidenced by patient independently emptying bag and changing the wafer. And of course, this was prior to her decline. Readiness for enhanced coping related to patient asking for family to be in room as evidenced by patient able to have a real conversation regarding prognosis with family. Readiness for enhanced nutrition related to feelings of hunger as evidenced by patient having 3 to 5 small meals throughout the day. And again, this was prior to her declining to the point of really not eating anything at all. And then we'll look at potential nursing diagnoses. So first off, we have risk for dysfunctional gastrointestinal mobility related to patient not passing stool as evidenced by patient laying in bed and cancer invading GI tract. Risk for ineffective renal perfusion related to hypotension as evidenced by low urine output, and this was prior to her coming in last time, and while she was in the hospital, she was experiencing a lot of hypotension. Risk for complicated grieving complicated grieving related to patient not discussing prognosis with family, as evidenced by tearful and statements of hopelessness. And this was prior to the hospice consult. It was after her scan that they decided to do palliative chemo. So it was the first time that she had heard that there was no cure. So that was when that diagnosis I thought would put her at risk for. And actual diagnoses. Excessive fluid volume related to low albumin is evidenced by +3 pitting edema on extremities, and this was the case when she was first brought to the hospital this last time when she had the excruciating abdominal pain. Imbalanced nutrition, less than body requirements, related to patient eating less than 1,500 calories, as evidenced by 10-pound weight loss and low blood protein and albumin levels. So she was receiving TPN, however, she still is losing weight. Activity intolerance related to decrease in activity level as evidenced by patient not ambulating out of bed, only to use restroom with assistance. So now we will look at some potential outcomes for each of the different kinds of diagnoses. So for the wellness, we have the readiness for advanced self-care diagnosis, and some outcomes for that. We have that the patient will empty colostomy independently, measuring the output correctly, and that our patient will be changing the wafer and bag independently and correctly, and not having any signs of leaking from the ostomy. And then with the diagnosis of readiness for enhanced nutrition, again taking place prior to her decline in the disease. Patient will be eating 3 to 5 small snacks / meals per day of at least 200 calories each, and this could be in addition to the TPN. And the patient will gain 5 pounds within the next month, not week, gaining 1.5 pounds per week during that month. And now looking at potential diagnosis outcomes. So the first diagnosis, we have risk for ineffective renal perfusion. So our first outcome is that the patient will trend down to baseline creatinine of under 1.2, and the patient will maintain a blood pressure of over 100 systolic and over 60 diastolic. And then the next diagnosis was risk for complicated grieving. So some outcomes for that would be that the patient will show emotion related to prognosis of disease, whether it be crying or acceptance, just some kind of emotion rather than the numb feelings that she was having. And that the patient will involve the family in discussion with the doctor and hospice. And then the actual diagnosis outcomes. So the first diagnosis was excessive fluid volume. So some outcomes for that would be that the patient's output of urine will exceed the input of fluid to help get rid of that excess fluid volume, and that the patient will no longer have that edema of the extremities, or that it is decreasing, trending towards no edema daily. And then the next diagnosis was the activity intolerance, and some outcomes for that are that the patient will ambulate independently to the bathroom, and that the patient will be able to walk at minimum of 2 times daily, whether that be just around her living room or just getting up out of bed and moving around. Alright, so when we think about these outcomes and diagnoses, we think of how we can prevent these things from happening. And there are 3 different preventions, primary, secondary, and tertiary. So the primary, that is primary prevention before a reaction to a stressor occurs. And with secondary prevention, That is the treatment of the symptoms following a reaction to a stressor. And the tertiary prevention is the maintenance of optimal wellness following treatment. So, the diagnosis that we are going to be looking at how we could prevent is the excess fluid volume related to the low albumin levels, as evidenced by +3 pitting edema. Oops, sorry about that. All right, primary prevention. Um, so, some things that we could do to prevent this fluid issue would be to monitor that patient's input and output, and if that input is greater than the output, we could be doing something before it gets to the point of +3 edema. Daily lab draws to monitor albumin, protein levels, and creatinine. Assess a patient's degree of swelling every shift, and if it starts to, the patient starts to get a little puffy, we could do something prior to, again, that +3 pitting edema. Auscultate the lung sounds. Hopefully, we would not be hearing crackles if we are preventing. And having the patient keep feet and arms elevated to prevent that fluid from settling in those extremities. Ambulating that patient at least 3 times a day, keep that fluid moving around the body. And daily weights of patients, seeing if that weight is trending up, meaning likely they are carrying excess fluid. Secondary prevention. So after the patient, after she came in with the +3 pitting edema, we look at how we can treat it. So administering albumin to draw that excess fluid back into the vessels, and after administering the albumin, giving Lasix and aldactone, we can rid the body of excess fluid. Elevating the extremities to keep that fluid going back to the heart and getting circulated, and getting that patient up, moving, ambulating. And the tertiary prevention, so this is after we have fixed the patient and got them back to their normal line of defense, what we can do to keep them from falling back into this excess fluid volume. So continuing to keep the patient on a oral Lasix pill. Lab draws weekly to monitor those levels, the creatinine and the albumin levels, and educating our patients on taking a daily weight and writing them down to see their trending weights, and teaching the patient to check for their own edema and signs of edema. So, rings getting too tight, socks indenting in their ankles, and things like that. That is all for the presentation. Thank you for watching.